thanks for all of you for the opportunity to be here with you today. So I'm going to discuss with you an approach that we take to kind of build a personalized prediction model that can predict outcome for patients with a form of blood cancer called myelodysplastic syndromes. So myelodysplastic syndromes are the blood cancer that typically happen with the patient, older adults, and associated with very low counts, and there is tendency to progression to acute myeloid leukemia. Now, the survival for those patients can be measured to some of the patients over years, but some of them can be measured in months. Now, prognosis in MDS and oncology in general is one of the most important things that we can do, because after we make the diagnosis, the next step in treating the patients is stage their disease or identifying the risk. And that's extremely important for the patients because it helps them understand their disease, set up their expectations early, and try to help them to understand what they expect throughout their journey. Of course, the first question from our patients always, how long are you going to live? Now, for the treating physician, it's also important because all our consensus guidelines and treatment recommendations are based on risk stratification. We typically stratify our patients into lower risk of progression, lower risk of progression to acute myeloid leukemia, and higher risk of progressive disease, shorter survival, and a higher risk of progression to acute myeloid leukemia. And you can see here the treatment algorithm for those patients are different. For example, for higher risk patients, we tend to offer them transplant upfront as a curative option. We don't offer that for lower risk patients because the benefit from the risk from transplant outweigh the benefit. So you can see here, if we have the patients that we label the disease as a higher risk and the disease behave like a lower risk, we're changing the management, or maybe we're over-treating this patient. And vice versa, if we have a patient that our model told us that this patient is a lower risk, but the disease behave like a higher risk, that becomes also a problem. Now, what we also found that we are predicting for the patients and when their actual survival is completely different. So if you take, for example, 1,500 patients with MDS, you try to plot their survival. So on the x-axis here, you see this is the traditional prognostic model that we use in MDS called the International Prognostic Scoring System Revised. And these are the categories that you come with the model. So we typically assign to the patients, let's say, low risk, and we give a median overall survival and AML transformation. On the y-axis, you see here the survival probability of the patients. In the orange triangle, you see patients who are dead, and the green circles, you see patients who are alive. Now, if we took a look, now when we talk about averages, yes, the average survival for patients with low risk is higher than patients with intermediate. But when we look at specifically at each individual, you can find here some patients with low risk, they behave actually worse than some patients with higher risk. You can find patients with intermediate risk all over the place, some of them like lower risk, some of them like higher risk. And this is really tend us to ask a question, can we build a model that can provide personalized prediction that is specific for a given patient? And in order to do that, we kind of took an approach to harness the power of artificial intelligence and machine learning to help us to do the model. So what we did with machine learning, you can take clinical data, genomic data, or any type of data. We plug this data into an algorithm, and then we want to know what's going on in the algorithm. So everybody talk about black box and machine learning is a black box. There are several techniques that we can extract features from the model. In other words, trying to ask the algorithm, what are the important variables that impacted the outcome? And then we extract those variables and we rebuild the model. So this has two implications. Number one, at least we know what the algorithm is doing. And the other thing is try to learn from the algorithms something new that we never seen before, using traditional statistical methods. So we took clinical data, demographic data, genomic data. We have a training cohort from a Cleveland clinic and a Munich leukemia laboratory in Europe, and we validated our result in Moffitt Cancer Center data from Moffitt Cancer Center. We run this data through the machine learning algorithm. We extracted very important variables, and at the end, we come up with the final model from the algorithm. Now, when you have this model, there's no way you can use this model in the clinic. So we have built a web application tool, and you can see me here on the web application changing the clinical characteristics and the mutation. It calculates calculate, and you can see the survival curves of the patient change and the survival probability change. Now I'm putting some poor risk features for this patient. I'm hitting calculate, and now you can see it's a different survival for these patients. Now when we look at this approach and we compare it to traditionally the current models or the standard care of models, they are IPSS and IPSSR. This approach significantly outperformed these models. Now in the past we have incorporated mutational data into the IPSS and IPSSR, and we have shown that incorporating this data can improve the predictability of these models. But with this machine learning approach and artificial intelligence, we're able to achieve much higher accuracy in terms of overall survival prediction, as well as leukemia-free survival. Of course, this work will never be done without a great collaboration from collaborators in the United States and Europe. This is from the MDS Research Consortium and the Munich Leukemia Laboratory. And of course, the biggest thank for our funders and all our patients who participate in our research. I would like to thank all of you for your attention, and I'm happy to take any questions, I guess, after we come.